one of the neurologists here at Pride, and I came here in 2013 actually, and here was no neurology service, and from that point the service just has grown. But initially it was really lovely. I was very much relying also on the surgery and medicine department because I was the only neurologist, so I needed other people to help me out in the service so that neurology actually could grow. And it was really lovely to have the input, particularly from surgery and medicine with the cases. That was part of the reason the service has grown so nice. Pride was a fairly new referral center, so not so much. However, what I heard, it was actually our friends. So a surgeon worked here who I knew from a previous job, and he said how lovely it is here. So then I came here and I saw the hospital, and I was actually really quite impressed with the facilities here, and the people seemed really, really friendly here as well. And with the years I have also grown to like the area here, which I really quite enjoy. So Pride or Derby is not really an area where people necessarily go when they want a lot of action, I would say, but it's more an area where people can enjoy themselves. There's a lot of nature around, a lot of people who want to build families here. It's really a nice place, and it's actually quite central, which also was good for me because I like traveling as well. So when I started, I was a neurologist, so I saw all the patients by myself, combined initially with the other services together. And then we were able to recruit initially one other neurologist, and then we could cover most of the service ourselves. And from there, then it actually has grown quite rapidly because we then started to offer also training programs. So I'm a diploma holder in neurology, so I can run residency programs. 2017 started the residency program, and that same year we started an internship program specifically for neurology. And with this also my job role changed a little bit. While I still love seeing neurology patients, it's quite a lot of fun. I'm also coming more into the role of organizing the service and of course overseeing and supervising the residents that they become neurologists and that they become good in their job. So with the way I started, Chris is our first resident, which I'm really happy with, and he's really amazing. He did a great job. So the way I start training them is, for example, that initially they will be one person with me. So we kind of be one person with the patients all together. For me, they can go straight to surgery under supervision, everything under supervision. And he had quite a bit of experience prior to it with surgery, for example, so he was learning fairly quickly. He's a very good surgeon. What's most important for me really is that he really cares for the patients. So that is really incredible what I can see him, and actually it's not just him, it's the whole team. Our nursing team is like that. So the team is for me the most important, because I do think that we can achieve the best for the animals if we are working in a team. One is of course the care for the patient, that you like the animal, that you can examine the animal, that a little bit playful is the best assessment I find you get with a patient, and also that you go the extra mile. If you really like the patient, you care for the patient, then you go the extra mile. And this is also part of it, is the team discussions, for example. I just know so much and someone else knows something else, and only if we bring all our knowledge and expertise together, then we are able to provide the best service and best care for the patient. And that is within the neurology service, so within our own team that we discuss cases, and we do that quite a lot, but also with other services. For example, I'm here at the MRI unit, so that we have also imagers where we discuss patients with, because an imager looks from the purely MRI point on the images, whereas I have the clinical input, and to combine, hopefully we get the best approach, and that applies also for surgery and for all other medical cases and so on. So we work quite a lot with the other referral departments. For example, if it is a patient where we think it is not just neurological patient but also other conditions, For example, we had a recumbent patient in intermittently walking, and initially we thought it might be neurological, but on further examination we found a lot of orthopedic conditions. So now the question is, maybe it's an orthopedic condition. So for that one was immediately able to speak to our orthopedic surgeon, and that's a nice thing. So we have in our little vet's office here, we work together, and then I can very, very easily approach my other colleagues, and then we examine the patient together. The clinical examination is still the core for me. That's all further diagnostic tests are really based on the initial clinical examination. My days are actually by now quite variable, but a normal clinical day would be that I would see certain emergencies. In my current role, because we had a new resident starting just now, it would be to supervise. So I supervise the resident, speak to the client as well, get the patient in, and most of our patients require an MRI scan. So then we would speak with the anesthesia and the imaging service to book a slot for an MRI scan. Then we do the MRI scan, and depending on the finding, if it's a surgical patient, then we would, and it's emergency surgery, let's say that, then we would move straight to surgery. So that would be a typical spine per day. And then I do a lot of organizational roles as well by now. Yeah, and that's also something I do. With the residents starting here, the training program starting here, we have quite a lot of training within the neurology service or study. On Mondays we have, for example, the clinical club, so rounds from the whole hospital, and then throughout the week we have a journal club. We have another day for an MRI rounds where we discuss MRI cases, interesting cases from the week. Then we have book club where we discuss neurology books. So this gives not only the resident the opportunity to learn, but also for me to keep up to date with the literature. Typical case would be a PAC with malformation on the spine where the facets are not present, and they cause the secondary subarachnoid cyst. And initially we were actually not quite sure what this was about, because with MRI we don't always see the facets there, and that can be easily missed. But now, at the moment, we are also in the discussion to say, do we do fixation for these kind of patients or not? My colleague Juanjo just did a surgery where we fixated a PAC spine with the subarachnoid cyst, and also treated the subarachnoid cyst, and generally they can have a good outcome, and we feel that they have a better outcome when we do both together. I overall think we provide a really good service, partly because our heart is in the work. So all the neurologists, we really love what we're doing. We want to do the best for the patients that we can, of course within our limitation, but then with the growing service, I do think there's a higher opportunity that we can do that. From the facilities, we have 1.5 Tesla MRI here, which is important for us always, CT scanner, and quite a lot of other little, what we call toys, which are really beneficial for doing this work. And also we have supporting from the other services for advanced spinal surgery, which we love doing here. So yeah, I do think certainly within the UK or in the world, we are part of the referral service that provide a good service, yeah.